Thank you all for joining us today. We are on Facebook Live and wanted to just get into our conversation. And it's really an important topic that we cover in light of everything that's happened over the last year. We wanted to focus on a follow-up discussion on COVID-19 1 year later. So I'm Cook County Commissioner Donna Miller. And just over a year ago, I started a series of Facebook Live town halls with experts on a variety of topics related to the pandemic, because of course, this was all new information. Everything was changing from moment to moment. And we wanted to make sure that not only people in Cook County had important information, but anywhere, because the information is applicable to anyone. But we had to really come to grips with this pandemic and learning about this disease. This is our second follow-up town hall, and this time we're focused on equity. We are graced to have with us today Dr. Maybank and Dr. James, and they are going to talk about what they have learned in this past year dealing with COVID-19 and to educate us on the role that equity played in the evolution on how we dealt with this disease. I believe it's really important to talk about the disparities in healthcare and the outcomes that have existed long before COVID-19 and how these disparities contributed to the adverse outcomes that everyone is all too familiar with now in Black and Brown communities, not just here in Cook County, but across the entire country. As we have heard and we'll hear more about, is African Americans in particular have been disproportionately impacted by some of the underlying conditions that have affected the severity of the virus, including chronic kidney and cardiovascular disease, asthma, and obesity. And as a note, these are the top disease states that have always been at the top of the list, regardless of COVID, in Cook County and beyond. So the crisis shined a light on the disparities, which have been rooted in generations of systemic disadvantages in healthcare delivery and healthcare access in communities of color. And in African American communities in particular, I'd like to give us a little history lesson, which they are quite apt and able to do on this topic. Lastly, we're going to be talking about COVID-19 vaccines and how they think the distribution has been handled from an equity standpoint, and maybe touch on some of the best ways to educate our communities on the importance of getting vaccinated. Because as we know, we still have a ways to go. As of this past Friday, May 21st, because today is May 24th, the numbers in Cook County Department of Public Health indicate that Black and Latinos with at least one shot was at 32.5 and 34.2% respectively. And this is in suburban Cook, so this excludes the city of Chicago. However, the numbers are probably around that same range. So what does that tell us? It tells us we still have some work to do, educating, getting people out to get the vaccine, and really making sure that their fear of the vaccine is answered in a not only educational way, but in a way that makes them feel comfortable. So I want to thank our distinguished guests for joining me today, taking their time out of their busy schedule. So without any other background information, I'd like to introduce them and turn it over to them for some opening remarks. So Dr. Alethea Maybank is the Chief Equity Officer and Senior Vice President for the American Medical Association. And Dr. Brittani James is a co-founder of the Institute of Anti-Racism in Medicine and Assistant Professor of Family and Community Medicine at the University of Illinois College of Medicine. So thank you both so much for joining us. And I would just love for each one of you to just give us a brief introduction and highlight where we've come from last year to now, and then we'll get into more of a conversation. So Dr. Maybank, you were with us last year, and I appreciate you joining us again. So let us know from your perspective, what's going on?
That's such a small question, right? Well, it's great to be here with you, Commissioner, and great to be here with Dr. James as well. That's part of the story we can talk about, of just the importance of being a network and connecting with one another as physicians of color during this time, and all the opportunities that this time brought as related to that. But, so now, we're a year later. I think probably the greatest news of it all is that we do have the vaccine. Unfortunately, though, to the expense of over 500,000 people who have had to pass away from COVID-19, it was a pretty bleak year for us, in this country and worldwide. There was the intersection of politics and policy, and how that really influenced our rollout of how we were going to help protect Americans initially, and provided actually some unfortunate roadblocks and probably some slowing of our response, especially at the national level, and that impacted what was going to happen at the local level. However, we saw many communities, really work and figure out what to do, and work to do within their context of the public health system and the healthcare system. And I think, when we look to see all of that became available, I think, to Americans in a way that hadn't before, is just even this understanding of these distinctions of these systems of public health, and what public health was to do and what healthcare was to do. And I think it became quite obvious of the importance of our public health system, as well as the lack of infrastructure, and really the lack of investment in the infrastructure. I'm a public health person by heart. And I'm very clear, public health is actually a pretty well organized system. They have they have the 10 essential public health services. They know what they're to do, but they have been poorly funded for years and years and years. And so I think it really showed itself, over this last year. And I think that these opportunities were really exposed, to many Americans. And then on top of that, the exposure of these inequities that have been longstanding became ever present. I joke around to some levels. So my mother, would always ask, what am I doing? What is, and I would share equity, and, for years, and she had no context to that. But then this year she says, I'm hearing that word all the time, on the news, and I guess I'm kind of getting it, and because it was over and over and over. So I think we're now in this space of this country where we're clearly naming the inequities in terms of a description. We know they exist. Folks have been, naming some of the reasons why. And I think the public murder of George Floyd kind of created that further intersection of a really deep and fundamental reason why these inequities exist, as in terms of structural racism. And so that really, I think, propelled healthcare, especially public health, yes, but healthcare especially, to really start to dig in, examine, and name, racism as a structural and root cause of why these inequities existed. So we're now in this time of, we have a vaccine. I think what has been really become apparent is not only do these inequities exist, but they persist, and they're really difficult. I say that in a light way, to some degree, but they're really difficult to address, and it's really difficult for folks to understand how best to prioritize and how to redistribute resources, because that's the fundamental piece of what equity is about. And now they have had the opportunity, as it relates to vaccines and many other things, to kind of redistribute, but it's challenging. It doesn't come naturally to systems to do, and people to do if they haven't been doing it. So there's a lot of work for us to do still in the equity space, but I think what's the big difference is that people are now naming it, talking about it. It's not unfamiliar in the way that it was before. I'll just stop there. There's so many other things to say, and I'll let Dr. James speak.
Yes, thank you. Well, that's a great, we have more to talk about for sure. So Dr. James, please, thanks for being here. And why don't you just tell us high-level overview?
Yes, thank you again, Commissioner Miller, for having me. So always good to see you, Dr. Maybank. I always love hearing your perspective as well. But, my perspective is definitely colored by being a frontline provider in this. And really, I work on the south side of Chicago and South Shore. So, my patients are 100% Black, disproportionately without, insurance, or they're on Medicare, Medicaid. And I work at a federally qualified health center. And so I really sit at this intersection of sort of governmental policy, frontline patient care, and just really working a historically disinvested, a community that's been disinvested in along racial and economic lines. So that definitely colors my perspective. One thing I think a lot of us who have sort of been in this space understand, of course, that none of the disparities that we see are new. They are certainly persistent. We can trace them all the way back from slavery. We see this in the 60s. Dr. Martin Luther King speaking out about some of the healthcare inequities that we still live with today. So we are a long tradition. I think when I reflect on the last year, what really stands out to me is just sort of the ways in which the floor absolutely fell out of our healthcare system. I mean that as literal as I can be. We have patchwork healthcare systems that really just folded under the capacity, under the weight of everything that happened. And I think the big takeaway lesson is that, as predicted, the people who are bearing or bore and are bearing the disproportionate brunt of that are Black and brown communities and rural communities, and people who are certainly poor. So I've heard already the pandemic referred to as the Great Pause. And I just love that so much. And I think for me, when I'm framing and sort of reflecting on this past year and what's ahead and what's behind us, that really stands out to me as a hallmark of this time. And what people say is, all of a sudden we had our ways of being in the world, our systems that have been running, the same way for centuries, essentially, fundamentally, and what it's done to, to disenfranchise people of color and poor, especially if you're both of those things. But this pandemic really forced us all to stop. It caused us to go into our homes. It broke our routine. And then in that pause, we see the, public lynching of George Floyd and sort of this racial overlay. And so to me, this has been just such a perfect storm to really, one, break the system that was already broken, right? So it's completely, the floor has fallen out. We see this in even something as from everywhere from, the unemployment rate when you're seeing, and then, Black folks, Black businesses, about 40% of Black businesses closing. We're seeing this in disproportionately impacting women, especially women of color, losing their employment. We see this even, I remember in the beginning of the pandemic with the hoarding of resources. That seems so long ago, but who had access to get food delivered to their apartment versus going to the grocery store? Who are the essential workers? So when I even though I'm a clinician, but I think of the social fabric of our country really flaying open. So that's a standout. But I think that's also in that pause is an opportunity, a time for us to question the ways in which we've been in a way that just has not happened, honestly, to me, in our nation's history in the same way, in the same magnitude. So I think certainly the wounds were there, but they have been brought to light. And when I say to light, in the mainstream consciousness in a way that we've just never seen. And so with that, a tremendous opportunity for growth. I think that what we have seen and are seeing with the COVID pandemic, but honestly, for me, from a health equity lens, what we're seeing with the vaccine rollout, and I'm sure we'll get into this a ton, but the disproportionate rollout of the vaccine is sort of inequity in real time. And so we're suddenly made aware of these deep injustices as a nation, but we're also called, and we have a real opportunity in real time to close those gaps. And the question is, can we recognize that? Can we heed the call? And I think we've done that with various degrees of success or not. But the takeaway for me is that we can't go back to the way we've been. I think that lid is open. Pandemic, a once in a 100-year event that has really shaken us to our core. And so I look forward to the ways in which things have been brought to light that just can't be put back in the dark.
Excellent. And you both raised really the question of where we've been in the past that's already been identified and where we are right now and where we can go. So I just wanted you to take a minute in each one of you define equity overall. And Dr. Maybank, you mentioned that you've been talking about it for such a long time, but now it's mainstream and everyone's talking about it. But equity overall and how it relates to healthcare specifically.
Well, so I'll start, and I'll let Brittani talk about how it relates to healthcare, because as she said, she's connected to it. Not that I don't know, but I think Brittani brings up a really important context in terms of kind of the national perspective of where I'm at, and what I see access to, what I have access to in terms of advocacy, policy, what's happening across the country, and then the local perspective and the actual kind of frontline perspective. I think both extremely critical, but pulls out different parts of the work and how we need to work moving forward. So for me, equity, I usually define as, in very simple terms, for folks who aren't familiar with it, is just ensuring that, as an outcome, this is as an outcome, ensuring that all people have the opportunities, the conditions, the resources, and the power to achieve optimal health. Now, equity is not just, that process, that ability for us to do that. We're very clear, and this is what everything that's happened over the year, that we all don't have those four things. All of those four things are really important in order to achieve optimal health. And we know there are differences in the conditions, the resources, as was already mentioned, that are at a neighborhood or local level that determine and influence the choices that people have, whether it's the type of hospitals they go to, what's in that hospital that they go to, what's in the neighborhood, what access do they have to, foods and vegetables, what access do they have to transportation, what access do they have, to jobs, and what types of jobs do they have. All of these things determine and influence equity and whether you're going to have it or not. And we're very clear in this country, and in all countries, right? It's not just an American thing, that there are systems and structures of power and really also oppression that determine what those conditions and opportunities are going to look like and translate to. And so, again, we go to the root causes of white supremacy and structural racism and sexism and all these systems that structure opportunity and assign value, usually with, a hierarchy kind of being determined. That's usually not fair. It's false. And it really is embedded into our policies. So our policies, again, for housing, as an example, many folks have heard about redlining now at this point, but many folks have compared to before, and redlining were policies of old, but still have lots of influence still today. And there are practices of redlining that still happen. That exclude people from going into certain neighborhoods. And living in certain neighborhoods. So then we're preventing access. We prevent so many different things down the line. So that's kind of an overview of kind of the construction of equity. But simply, I usually just talk about core to equity and achieving it is the redistribution of power, the redistribution of resources. And then justice is saying that we need to tear down those structures so that we do have this opportunity for liberation and joy, honestly, in the long run. So that's how I would define it. And just to put a little plug, is that, we just released our strategic plan as AMA for advancing or embedding racial justice and advancing health equity. I think these terms on the healthcare space, and as you said, people are hearing the word equity, but I'm not clear everyone really understands what it means, how to apply it, how it shows up, even with the best intentions. We know that there is great impact and potentially great harm, and that's what's happened to communities over years and centuries. And so we really try to take our time to explain some of these concepts in the strategic plan.
Gosh.
Excellent. So we are putting some of your quotes in the live stream there so that we can focus on those. So Dr. James, yes, from a frontline provider, and it's been so important, all the things you mentioned about being out there during this entire time, but also the equity component, and especially in the neighborhood that you're in.
Oh, yes. I mean, absolutely. I guess just echoing. So I'm obviously just simultaneously a fan, and I will also have to give a shout out to the AMA, strategic plan, which I've reviewed. I was truly and Dr. Maybank knows this, I was truly it was such a, it was actually a moment for me, because to really see such a mainstream, a huge organization, which actually is medicine, to like get it, for lack of a better term, and embrace that. And so I actually want to emphasize, I think we're actually in the middle of a paradigm shift. And that's really important to people who are kind of feeling fatigue in this work. I truly believe that. But, in addition to the great comments by Dr. Maybank, when I think of health equity, and this is more just through my lived experience and what I've seen, even again, as from a frontline perspective, that we can't talk about, when we talk about health equity and what it is like to improve the material circumstances of Black and Brown folks. It's really important. And for me, that racial healing component becomes really important, that joy as we're doing justice work. So as an example, during the pandemic, people are already sort of at a low, obviously. And then we have the George Floyd killing. And in my clinic, which my patients are 100% Black, I'm on the South Side, but so often what I heard was not just I'm losing my job, or, I'm afraid to go outside. What I heard was, I'm in so much pain. Are they going to keep killing us? And those sorts of things, that racial stress does something to your mental health, of course, but also your body. And so for me, when I frame equity, especially from a frontline perspective, we need part of that comes with reimagining how we deliver healthcare, how we deliver public health that allows for people to actually heal from racial trauma. So for me, that includes healthcare, trauma-informed care of healthcare professionals. That includes policymakers who understand the real weight of oppression, not just on the material circumstances, but also in the mental health of people. And also just holding spaces where people, minoritized groups can heal. So I think when we imagine, when we work toward health equity, in addition to the social, lifting the social pressures, employment, as Dr. Maybank was so eloquently putting, there has to be space, to me, in which my patients and all patients can just heal from the racial trauma we're already carrying, and we have to acknowledge that racial trauma. And really to be plain, I don't think that we can heal people of color and have them have good health, or until they face this idea that racism has really taught all of us of internalized inferiority, which limits our view of ourselves and our capacity, and then lift this name, and then address and lift, whether that through therapy, whether that through community healing, different methods, but actually work to lift that racial trauma and address it so we can heal. And I think that is part and parcel to achieving good health on an individual level, as I kind of deal with, but also as a community and as a society. We all have to actually heal from racial trauma too. I will also add, it's not just the work of people of color. White supremacy does something to white folks too. It makes it, there's no other force that you can go through your entire life without having a meaningful relationship with a person of color, really, a real friendship, a real love, a real kinship. That you don't actually see the humanity really in a real way of people of color. And that is a great detriment to our white brothers and sisters as well. So when I talk about, again, kind of off the rails, health equity for me has to include that racial healing for people of color, but also for white folks as well.
I would just add, can I build on that? Because I think I would even, Dr. James and I, and both of us, and I think many in the healthcare space who are kind of leading this equity work, we're so connected. Like, this is so much of our passion, our politics, our personal, our professional, right? It's actually a privilege that we have, and it's a wonderful privilege. And we also are part of it. Like, we don't escape it in being physicians. And I think that, for me, let me speak specifically for me during this time, there were just some realizations, and part of it is what Dr. James was saying as it relates to the trauma and healing, right? And doing that work is critical, and at the neighborhood level, the institutional level, even at AMA, right? This is about healing the harm of the past, repairing the harm of the past, so that communities can heal in ways that are meaningful and just. But then the other part that really speaks, and Dr. James mentioned as well, is this joy part. And there's a distinction, and I think it's really important because, during this time, we have worked a lot. We have worked a whole lot. And we have always worked a whole lot, as communities of color, as women of color, Black women. And we do it for all kinds of reasons of why we're committed to doing it. And oftentimes, right, have put ourselves second, third, fourth, fifth, whatever the line is, the number is. And recently, I had somebody, I was explaining to them and sharing, what, the strategic plan is and what it is, and, using the language, and they stopped me in my tracks, and they're like, I get that's your legacy, that's been left to you. And that's that legacy for all of us in terms of doing this justice work. But understand the legacy was also for you to have joy. Your ancestors were fighting for you all, for us to have joy. And I think, it's not a typical part of our conversation in healthcare, but I'm going to tell you, I'm going to say it so often, and I don't care who the audience is, because what has happened and what needs to happen less moving forward is the intellect, I'm not even gonna be able to say it. Oh my goodness.
Intellectualization.
Yeah, intellectualization of harm. Like that has been happening, and I've heard it over and over and over. Even in this COVID time, when people are naming racism and naming inequities, and they, it's like all of this kind of, lofty talk around it, and the data, which is very important. But we have to center the humanity of people. And we have to center what is right and what we deserve. And I believe that is part of this work. There are the technicalities of it that all need to happen, all that we already mentioned. But there is a part that needs to happen that shifts hearts and minds and hearts and souls in different ways. And that is part of the work too. And that's exhausting. God knows that's exhausting. But I just say it all to say is that I think it's just really critical that we talk about our right to have joy.
Agreed. Completely.
Agree. That's excellent. And we are so fortunate as our whole community, our country, however you want to phrase it, to have both of you in this work. Having you at the table really, really matters. So thank you so much for that. I wanted to also just dive into a little bit. I mean, I know it's on a high level that we have the changes that need to come, and the policy portion of that, Dr. Maybank, in your strategic plan and how it's going to be rolled out to the public health, because that's one thing I always like to focus on too. As being a county commissioner, we are the public health officers as well, and manage that process by having the largest public health hospital here in Cook County. But and the public is everyone. And sometimes people forget that, like, we're talking about you. I mean, whether you come to Cook County Hospital or another hospital, the public health matters to all of us, and it affects all of us. So these strategic plans, the work on the front lines, all of that matters. So how important, or not important, the equitable piece of that preventative healthcare plan and making sure that rolls out and how it relates to overall public health. Could you both kind of talk a little bit about that? Dr. Maybank, you want to go?
I was going to let Dr. James go because I just spoke a while, so I want to share space.
Go ahead, Dr. James.
So you're asking how preventative medicine might look in this new. So when I think about this, and obviously I eat, sleep, breathe preventative, and it's so, the temptation is always, again, even especially for me and us in healthcare who are providers, like frontline providers, you get so focused on like, oh man, I'm looking at this one disease metric, and I'm looking, and and our public health colleagues are so much better at this, pulling a step back. And when we talk about prevention, it has to be at a community level. I think that, and that's what my resounding takeaway is. Of course, you learn that, but to live it. In other words, for me as a provider, I can talk to you about your individual methods, even your individual barriers, maybe belief systems that may be holding you back, but it just drastically pales into what would happen if my patients lived in a community that supported their health. So I think even for us in health and medicine, we really, really need to lean in to a community definition of prevention, which means partnering so closely with our, public health colleagues as we're building this. And again, Prevention to me also includes something like resilience, of course, on an individual level, but like community resilience, having a running, I'm thinking of an example of, during the pandemic, we're suddenly trying to get, vaccine sites to communities. How amazing would it have been if we have, community centers that have that capacity that can switch into vaccination centers, but on the other times, they're doing classes. And so really building that community infrastructure to me is part and parcel. But I think the biggest thing is we just have to come to understand that this sort of one size fits all for prevention. We really need to tailor and make culturally competent interventions for communities of color, for communities that lack resources. When my patients are told, you got to get exercise, go out and walk on your street. But they literally, multiple patients say, gun violence, I'm afraid to leave my door. So what does prevention look like for them? And so again, I say the word a lot, reimagining. But I think we are at this space of opportunity to reimagine what is, and that includes prevention and what that looks like.
Yeah, and I think, so to build on that, part of the other work is that we have to work on the narrative of what creates health in the first place in this country. And, oftentimes it has very much been, connected to health care and sick care. And health care, gets kind of the most attention. That's where the dollars are. And, it's very much driven by profit. And what we've come to realize, again, is the role and the importance of public goods. But oftentimes Black and brown people are left out of that public conversation in really meaningful ways. I understand there may be services at the neighborhood level, but really, is it something it's really truly for communities across the country that have been excluded often? And so we need to work on how do we create a narrative of all the context of what creates health, what's in the neighborhood, the opportunities around prevention, and looking what we say upstream. So in the plan, we talk about moving upstream, and some of these have already been mentioned in what we're saying. I'm just introducing another word, nothing novel, just a new word of saying we need to focus on things such as the social needs and other conditions and factors within neighborhoods, such as, again, transportation and what's available, what's not available. And then even higher than that, and the policies that influence those. And healthcare needs to pay attention to that instead of just focusing on what is happening in the doctor's offices and the hospital walls. And I think that's what really COVID also elevated, is this opportunity. And it's been visited over and over again in history. This is not a new conversation, but to better bridge public health and the healthcare system together and connect those dots in much more meaningful ways than have ever been, and have linkages in ways that have never been as well. But if we don't really evolve the narrative around what creates health, that reimagining, which I absolutely agree is really important, opportunity at this time, will not fully happen. And so I think part of our messaging and some of the work that we're working on is how do we get physicians, where a lot of times, again, the power, I'm not saying rightfully so, but that's where the power is. And sometimes the narrative is not fully complete with physicians, to better understand all of these contributions to what creates health. And then what is their potential role, as physicians, but also as the institutions of which they work. And there are more and more efforts and opportunity in terms of, community benefit and what institutions are doing at their neighborhoods. Rush being a good example of that, and other institutions in Chicago. Westside United, right, is an opportunity where you have 6 healthcare institutions coming together to do upstream investments to kind of see if they can have some impact over time. And so that's where, we really need to push and we need to move. And then it also means we need to train med students differently as well, which is a whole nother conversation.
Yes, well, we can have that conversation another time. I would love that. So let's just get back. I see a question, but I'm going to get the questions at the end, if that's okay. But I wanted to focus on the vaccine and the rollout of the vaccine in an equitable way, because we all have heard that, and I've heard it really on a daily basis from my role here as a commissioner, that they wanted to make sure equity focus was in every conversation. So from both of your perspective, how do you think that looked from a national rollout down to the community level? And if there's anything that could have been improved, because we still have work to do, as I read those numbers, we still have at least 60 to almost 70% in the African American and Hispanic and Black and Brown communities to get vaccinated still. So how are we going to make sure they feel that they're part of this?
Wow, well, for me, when I'm looking around kind of the nation, how do I say this? We have definitely been influenced by, what's going on at the national level, and the sort of sanctioning that, the policy environment that we came through, under the previous administration compared to now. I think that that's really different. I think that you're starting to even see how much of a difference we have had with, administration that really embraces the need to vaccinate everyone, that everyone is American and everyone counts. One thing that's been really powerful when you look at somewhere, and people may not aware, but somewhere like California, and recently they got their numbers of COVID down to like 1%. But the thing about them that I think is so hallmark is that they actually, under the leadership there, California Surgeon General, African American woman, has gone above and beyond to really bridge this gap and vaccinate Black and Brown underserved communities. And what's so interesting is that, to me, they're living proof of what happens, that when we prioritize equity for all people, everyone wins. So we see, that number drop so profoundly. Contrast that to somewhere like Florida, which has, really had, at a policy level, political level, just has not had the same engagement or investment in Black and Brown communities. And we see their vaccine rates reflect that. We have a profound disparity in the vaccines between Black and Brown people and white people in Florida. And then what's so interesting is that we see these gaps, but the country is opening, and that we've sort of said it's been a success. We got our numbers down, and what's left out of that conversation is, again, Black and Brown communities. I will say my fear is that we're moving to a place where the pandemic is over. But essentially what we're doing is ignoring the reality of Black and Brown folks. And again, so I have this sense that it's kind of the same story again, in which are we really out of the pandemic? I think we have to be very clear about who is out of the pandemic and who isn't. And if we're honest with ourselves and we face the fact that we're really just talking about white Americans, then again, we realize that we have to remain vigilant, that we have to remain dedicated to closing these gaps. The gap in vaccination for me is no different than any of the multitude of racial health disparities that we're battling. Oftentimes we measure our success on what has happened in white communities to the detriment of communities of color. So I just really, truly hope that we don't fall into that same trap, and that the conversation is going, although we are opening up. So, that's the state. And I think we have to we just have to start being honest with ourselves and telling the truth.
Yeah, I think I would totally agree. And I think to that honesty is the lack of data that still exists, the infrastructure to collect the data, the policies and the data sharing to collect it. And I think overall, the will, there's no, I think we have all, Dr. James and I have both been part of efforts to advocate for better data collection and accountability at the state and national levels. However, there still isn't the full will to do that, for many different reasons. We know individual providers oftentimes are actually even uncomfortable with asking about race and ethnicity. And then I think just the overall, so that's the data part of it, but then the tools of how do you really operationalize equity and racial justice, the questions that you ask to help you get to the point of how am I denying care potentially or denying access, really they aren't available and well, they're available. Let's put it this way. They're not well distributed, and the community has not been well educated on what that is. And the health system community, whether you're a payer, a hospital administrator, or a provider of some sort, those questions aren't there. And I just give an example of questions if people want to ever know and look it up. It's like the Racial Equity Toolkit, gives a series of questions that you ask as you're trying to set up systems for justice, right? And the two that really always stick out of my mind is, what are the unintended consequences of the decision that you're about to make? And how are you going to mitigate those unintended consequences? And so those are very intentional opportunities in the process. And I would say a lot of folks don't quite have that. And clearly also centering the voices of those who have been historically marginalized, and not just their voices, their ideas, their power within the context of your processes and systems. So there's that, right? So there's that gap. But I also feel, during this time, there has been efforts to push by, several equity leaders around the role of institutions and shifting it from the patient, right? And ultimately the patient or the resident is really dependent upon what you have done as institutions, how you have showed up for years, how you have excluded potentially for years, and people are responding to that. And so there has to be accountability to that if we're really truly invested in doing equity work. And so the frame has shifted to kind of the trustworthiness of an institution, right? And it's not just Tuskegee that, for some of us, it's a little annoying just to hear about Tuskegee. Like, we get it's a very important context. I don't want to take away from that, but understand people experience that every single day, and that kind of exclusion and that kind of harm. And so there's been more push, not enough, around, the trustworthiness of institutions. How are you going to show up? And to the point, Dr. James mentioned as it relates to who is leading some of the efforts for equity, and Dr. James provides some examples. There's, Dr. Stanford in Philadelphia, who organized tremendous vaccine, distribution opportunities, and how BIPOC physicians of color, Black, Indigenous, and people of color, have been leading efforts across the country. And so we're actually going to be working with the CDC over the next couple of months and year on identifying those folks who have employed those strategies and put those strategies forward to help support Black and Brown physicians and who have been working in community and collaboratives to not only expand and strengthen their work, but to evaluate their work. And this is an important part of, again, if we want to move the work of equity forward, we need to measure what success looks like, we need to know what success looks like. I think that's a gap too. And then lastly, the other thing that I'll just say again, or it kind of combines both who's leading and the trustworthiness part, is I just think the efforts of many Black and Brown physicians and healthcare providers to be leading messages. And so, there's a campaign called The Conversation by the Kaiser Family Foundation with Dr. Rhea Boyd, who has really been at the helm of that. I think they actually have a conversation today. I think she's in conversation with former President Obama and I think Eva Longoria as well, with the Made to Save campaign. That is on. So those are important. Like it's all an and approach, it's really totally hands on deck. We're not at the point where we can just do one and not the other.
That's great. We should maybe post that link about the conversation so people can dig in on another level, but it's just so important, everything that both of you have just said. We have a few minutes left, but one other thing, if both of you could share, how can people help those people who still are reluctant to get the vaccine? I always feel like it's not just vaccine hesitancy, it's really lack of education or having someone they trust to provide that information to them. So what can people do if they're just in conversation with someone and they say they don't want the vaccine? How can we help? Because that helps, again, the public health.
I mean, for me, one thing that's been a lucky thing or good thing for me is to be in a Black body. So when I'm talking to Black patients, I encourage people to really don't shy away from using your own lived experience. I very easily say, hey, I get it. There are people in my family who are hesitant too, honestly. And I'm open enough to say I was nervous until I looked at the research myself. And just literally that level of transparency. And this is what I experienced. This is how it was for me. I think, especially when we come to the Black community, community. I know people very much lean into the mistrust and, but really, and honestly, when I have conversations with my patients, really what I hear is a gap of people actually talking to them directly. There's a lot of people talking about them and past them, but very few opportunities where someone sits down and say, tell me what your concerns are. And so that, because I'm able to do that and I draw out so much, that tells me that it's not happening, because they're not as stalwart as I think this image that you have, people sort of digging in their heels. What I actually have found is people are terrified. If the people who are really hesitant, there's so much information coming at us at once, even as a healthcare professional, that especially in the beginning, there was so much we didn't know. It seems like every day there was a different recommendation. So if we're sort of feeling that buzz, we have to put ourselves in the position of everyday folks trying to sort through all of this information and what feels like a life or death decision, because literally we have it's such a scary new entity. So I think having very honest, transparent conversations and not shying away from bringing in your own lived experience and your own fears, that vulnerability, I think means a ton. And I think also just making sure that, broadly, we're putting in systems in place that allow people to get this vaccine. And so we have to look at what are our employers doing? What are their responsibilities? What are their policies around that? Again, we talk a lot. I never like to talk about trust without talking about access. So, we have this period of time where there were more people who wanted it of color than could get access. So again, I think a lot of us go to this sort of individual place, individual decision, because it's easy and you can hold it. But I think the bigger questions are, one, why have we arrived at a place where people don't trust medical institutions enough to believe, the messages that are coming out? Why don't people trust the CDC? And we have to understand that didn't happen overnight, and we can't undo it overnight. But what we can do is have meaningful, vulnerable conversations. We can acknowledge people's fears as rational and well earned, and then we can be vulnerable to share our experience. But most importantly, we can look at the broader structures of access and making sure that when and if they want it, they certainly can get it easily.
Yes, I totally agree with every single thing that Dr. James just shared. And I feel that is a really important, even at this juncture, when we know that, many of the folks who are willing, who were the yeses, have definitely gotten the vaccine. However, there still are more out there. And that our conversation and narrative, again, can't just focus on trust, but the access part, I think, is critical. And, this hits home. I mean, I'm sure Dr. James as well. And it's hard when you're a physician and you cannot convince, your own family members to get the vaccine. It's challenging. But it's so real. And so I think that's also the opportunity that we have as physicians of color, is that we do get it. We do get it. And we do get the hesitation. We do get the fears around it. We see it and we try to work through and explain with our family, but we also understand what it means to not be successful and to some level. And I would say maybe we are successful and just we're sharing the information and soon enough, our family members who are still on the no side, will get the vaccine. But it's not easy.
And I will also add, one thing that I had to definitely shift my mind on is this idea of shared decision making and what is success? Is my metric of success every person of color getting vaccinated? And I think that's a recipe for, failure in a way. That's impossible. But I have come to understand my role, and my mission is that people have every information that they need to make the right decision for their lives. So they have all their questions answered. And then on top of that, having the ability to get it if they want it. So I had to change that benchmark for myself, because you are so right. I'm living it too. And it hurts to, I call it like kind of just in the situation where I'm watching the destruction of Black folks from ivory tower myself. And that there's some, a lot of layers to that, but and if it's helpful for people, framing it as, or have I given them the space and the ability to make the best decision for themselves as your metric of success?
Absolutely. And because, and one of the things that you just realize, because it's not just the vaccine, you kind of recognize that if they do test positive for COVID, which has happened to several family members within the last couple of weeks for my family, that just means so many other things. So then it's like interacting with the healthcare system, and they're in other parts of the country. So what happens there? Like, it's such a trickle effect. But I just wanted to add into that, because that doesn't get talked about often. Our lived experience, I think, is really important as well as providers in this space.
Absolutely. And, as we see you guys just sharing what happens in your own family, that lets other people know it's a work in progress. The conversation doesn't just start from A to B and then that's it. A, just go get your vaccine. I'm a doctor, I know this. And so it doesn't happen that way. So thank you for making that point as well. One of the questions, we talked a lot about just the systemic parts of racism that affect health, but someone asked specifically about the impact of pollution and poor quality of water in communities of color and how that just adds into all of this, which probably is some of these disparities in healthcare that are high on the top of the list as well. Could you each just talk about that for a second?
I'll let my public health colleague go first.
So, the way that I think about it, and one of the ways, is not the only way, but is that healthcare is a system in this country in the same way that all the other factors that were just mentioned in that question, and they're all impacted. And so my frame is not only naming racism and systems that structure opportunity, but white supremacy and the hierarchy of human value that has also set up opportunity and structured opportunity, so that really every single system within our country is going to be affected and cause effect and impacts to people's health and harm people's health. And so from the public health point of view, all of this is to me it's one-on-one. It's another demonstration and a representation of how inequities plays out at the neighborhood level. We have heard about the impacts of pollution and the impacts, especially as it relates to asthma in Black and Brown communities. That was a core part of my work when I was in New York City Department of Health, and not just the downstream of treating asthma and helping systems respond to it, but also what are we doing at the neighborhood level, and what's the housing quality look like, and what's the environment, and elevating the importance of housing, as a key and strong public health determinant. But then, larger than that, what are the policies, as well as the systems, processes, and kind of historical context that have made communities more vulnerable? And again, it still goes down to the bottom line of like white supremacy and racism, in which decisions have been made that have not valued people, that have allowed the placement of whether it's truck depots or whatever it is within the context of neighborhoods. And so all of it is connected very explicitly. And, for me, we all have our roles of which we have to this space. And mine will always go back to kind of naming structural racism. I know Dr. James is as well, and white supremacy, and how this plays out in every single system of our country. And so it's all interrelated. None of it is disconnected. And we need to have the conversations in very interrelated ways.
Absolutely. And I will just add, again, agree 100%. And then, to really bring this home, think about this. If I have, if you can't even get clean drinking water, or, your air quality, you have poorly controlled asthma because, there's a highway by your house, and then you get COVID, so these things overlap, these things intersect. And to me, they manifest. And this is why, anti-racism in health, or dismantling white supremacy in healthcare and public health is so important, because at the end of the day, these structures that seem so nebulous, they boil down to real impacts on the body and in life, and your morbidity in your life. So we can talk about environmental racism as this sort of abstract thing, but it's not that. It actually has real visceral effects on the bodies of people of color and the minds of people in color. And we have to talk about that more. I just agree completely with Dr. Maybank.
And it crosses generations, right? And I think you mentioned Dr. Nadine Burke-Harris earlier, the Surgeon General of California, has done a lot of work on adverse childhood experiences, and that these traumatic experiences, whether it's racism or discrimination, the exposure to violence, the exposure to pollution, right? They all have impact later in life, like to chronic disease, and it's well documented now. And so really, again, I go back to like, who's paying attention, who's going to really value, who's going to do something different, who's going to operate in a courageous way, in a different way. Reimagining to me is going to push people, and would need to push people in a way that they have never been pushed before, to show up differently, I think, and show up differently as leaders, whether in government or the healthcare system.
Exactly. Oh my gosh. Well, we need to have a part 2 about the strategic planning portion of equity as it relates to healthcare for systems, and empowering individuals to ask hard questions of their healthcare providers if they don't feel like they're getting the right answer or fair treatment, or if they're being discriminated against. So that's a whole nother topic, I'm sure. But thank you both. I wanted to just give you like 2 minutes or 3 minutes each to do closing remarks. And this will be on the Facebook page forever, so we can share and continue the conversation. But Dr. James, do you want to just close us out with your closing remarks?
Thank you. And thank you so much for having me. I just want to say that. And thank you. Always good to share space with you, Dr. Maybank. But, for me, when I'm looking back, the question is, where do we go? Where have we been, and where do we go from here? I think that we have to just name and recognize that this can be it's a very scary time, but it's a time of great change. And we have the power to make it a change for good. Things are starting to open up again. The George Floyd's killing was, last year. There's a temptation, and I know we so want to go back to normal. We want to go back to what life was before and what that meant. But I think it's important that we redefine what normal is, because when we peel the layers back, what normal was pre-pandemic, there's some dark shadows for a lot of people, for so many people, and there's so many great opportunities to build back stronger and better. And so I think part of this conversation is allowing the voices, needs, and granting power, agency, resources to people of color to define their own futures, their own existence. It comes for me again in joy, and finding joy for people of color. And that for me is always the takeaway, and all of the work that lays in front of us, that we have to imagine a world in which people of color can be joyful and still strive for justice, because to me, I can't be joyful if I'm oppressed. I can't. And this work is certain part and partial. But how do we redefine wellness and well-being, and not just for individuals, but for communities, for society? And I just urge us to resist the urge to go back to that norm, because I think we can all agree it was too broken. So let's do better.
Yeah, and everything was said that I would say. So I don't have really much to add. I think the joy part is important. Also, I think there are doors that are open, these doors close. And so this is our opportunity to capitalize on some open doors and some alignment that we have not seen in this country before, to do something differently and to push, and especially with the lens of racial justice. So we need to push as fast and as far as we can.
Thank you both so much for your amazing expertise and being in this work and being leaders in what's happening as far as changing and reimagining and moving forward for the next generation. I think that it's important that they have the foresight and ability to see how things could be, and evidenced by your work, I think they will be able to do just that. And we'll be able to make some meaningful change on every level. And, I'm just so proud of the things that are in place right now that we can build upon. And I look forward to seeing that happen. So thank you all for joining us here today. This has been such an impactful conversation, and so many nuggets that we are able to take away. So Dr. Maybank, Dr. James, continue your good work, and we look forward to catching up with you again. Thank you.
Thank you.
Take care.